Yeah, so good morning, everybody present here, and a very warm welcome to all the delegates. So, we are privileged to kick off AIOC 2023 with our first day, first show program, and our IC is on management of surgical aphakia, which is common in every ophthalmologist practice, and we have a young dynamic vitreoretinal panel with us who are experienced in their own techniques of managing surgical aphakia. So, without wasting too much time, just start on with our first speaker, Dr. Sudeep, who's currently a vitreoretinal consultant in ASGI Hospital, Pune, and he'll be talking to us about management of surgical aphakia, a rundown on the techniques. Over to you, Dr. Sudeep.
Thank you, Shishir. So, aphakia treatment part. The incidence of aphakia post surgery has come down to less than 1%, but still it causes a lot of morbidity to patients. Then there are other causes of aphakia in the form of congenital aphakia, trauma, dislocation of lens, or hereditary disorders. So, how to treat it? There are different options in the form of spectacles, contact lenses, intraocular lens, or refractive corneal surgery. Spectacles come with their disadvantages with appearance, magnification, and roving ring scotoma, jack in the box, and pincushion effect, which all of us know. As well as contact lenses also have certain disadvantages in the form of foreign body sensation, corneal complications, lens spoilage, and particularly cumbersome for the older population. So, better is to treat these patients with intraocular lens. So, how do we select these intraocular lenses? Patient should be thoroughly examined for anterior and posterior segment. Then specular microscopy and corneal pachymetry should be done. Anterior chamber depth should be measured. Integrity of iris and presence of capsular support are particularly important to choose the proper IOL which we want to select. IOL power calculation, there are basically two types of formulas, axial versions and axial length versions formulas and refractive versions. So out of those two, axial length versions formulas like Holiday, SRKT and SRK2 are generally better. Several authors have recommended adjusting the IOL power because IOL will be calculated for in the back placement. So if we are placing the IOL in the sulcus, we have to reduce the power, or if we are doing SFIOL, we have to increase the power by 0.5 diopters. Earlier generation closed loop AC IOLs and lenses had used to cause lot of corneal complications. ACILs as such are not one size fit all. They have to be wide to wide diameter has to be measured and the size has to be measured properly before selecting the ACIOL. Modern open loop ACIOL like Kelman Multiflex are better than the earlier closed loop, but still they have their own complications in the form of corneal decompensation, UGH syndrome, CME. Sulcus, whenever there is a presence of good rhexis, it is advisable to put a 3-piece IOL into the sulcus with or without optic capture. Optic capture should be done because it provides stability, centration, as well as prevents the prolapse of vitreous. Then there is iris fixated lenses. Those are in the two forms, either iris claw or sutured. Iris claw lenses can be fixed anterior to the iris or retropupillary as seen in these images. Sutured lenses are sutured with the help of 10-0 Prolene suture, but there should be some form of capsular support available so that one haptic can be sutured and other can be rested along the available capsular support. Scleral fixated IOL started in 1980s as ab externo and ab interno procedures. Those specialized lenses used to have eyelets or 4-point fixation, 2-point fixation lenses used to be fixed with 10-0 Prolene or Gore-Tex sutures. Ab externo was better compared to ab interno because it was a blind procedure where needle was passed from under the iris externalized through the sclera. Blind being blind, it used to cause a lot of complications like hemorrhage, retinal tears, or retinal detachments. Sutureless SFILs were developed later because suture associated not erosion, endophthalmitis, or dislocation of lens over the long term were common. Sutureless was Gabber has given his technique in 2007 about sutureless fixation of SFIOL, in which standard 3-piece IOL was fixed with the help of two limbus parallel scleral tunnels. Later on, Agarwal has started fibrin glue assisted SFILs, wherein two scleral flaps were made 180 degrees apart, and the exteriorized haptics were then fixed with the help of glue and those flaps. Yamane has started his own technique of flanged intraocular lens fixation, double needle technique, in which two bent needles are used to exteriorize the haptics, and those haptics are then cauterized and left under the subconjunctival space so that they do not cause any kind of irritation. This is the diagrammatic representation of how Yamane surgery is done. Usually these are done 2 mm away from the limbus. Then there is X-nick technique, wherein one small 240 band piece is cut into 2.5 to 3 mm and it is loaded on a 26 gauge needle seen in this image, which is then used to externalize the haptic, and then this piece of band which is there on the needle is moved onto the haptic, which prevents the prolapse of the haptic back into the vitreous cavity. CMT Flex is a new innovative designed foldable IOL which has T-shaped specially designed haptics. Again, in this lens, scleral flaps are made 180 degree apart, and once these haptics are exteriorized, the conjunctiva and flaps, everything is sealed with the help of fibrin glue. There is one study conducted by Kelkar et al. Regarding the practice patterns in aphakia management in adults in India. So this was an online survey among the ophthalmologists in India. Interesting thing was, whenever there was no capsular support, anterior segment surgeons preferred iris claw IOL over SFIOL. And whenever SFIOL was used by anterior segment surgeons, they preferred sutured or glued techniques more compared to vitreoretinal surgeons who used to do sutureless or Yamane technique. This is the representation they have shown, how the anterior segment and vitreoretinal surgeon differed in the techniques of fixing the SFIOL. So they concluded that the choice of IOL and in the absence of capsular support differs between both anterior and posterior segment surgeons, and it is also influenced by the experience of the surgeon. Thank you.
Thank you, Dr. Sudeep. That was quite elaborate. So in interest of time, we'll move on to Dr. Prabhu. He is currently a vitreoretinal consultant in Arvindai Hospital, Chennai, and he has innovated the unique X-nick technique of SFIL, and he'll be talking to us about that.
That's it. Thank you, Dr. Verghese, for the opportunity. This is a video. Can I have the sound also? Can we have the sound? Can you increase the volume? So this is the reason why we introduced XNet. X stands for extraocular. I'm using XNet device, which is a commercially available product from Oralab. You enter the sclera at 1.5 mm from the limbus, and it's a pre-bent 26 gauge, customized 26 gauge needle, and pre-loaded with silicone stopper. So once your needle tip is inside, you just change the direction, come more anteriorly, and bring it out through the cornea scleral section. You can use a McPherson forceps to gently depress the section and bring it out. Sweeping sort of a motion is preferable rather than penetrating motion. And then what you do is just docking. This is all about XNet. The intraocular maneuver is avoided. You dock the haptic of the IOL at an extraocular, safe extraocular location. Once you dock it, you retract the needle and at the same time push the IOL inside. So this retraction and pushing should happen simultaneously, should go hand in hand. You don't retract separately and push separately. So once it is this is done, you don't do anything intraocular. As I said, intraocular maneuvers are completely avoided. And then the preloaded silicone stopper, this is a dual protection silicone stopper. You push it along the shaft of the needle and pass it on to the leading aptic, which we are going to exteriorize. Just catch hold of the aptic, gently disengage the needle. That's it. So now you can move the silicone stopper to the very tip of the aptic, and then so that you get additional length of aptic intraocular, so that your trailing aptic maneuver is easy. And do it on the other side. Enter and change the direction of the needle. And you can use McPherson forceps to gently depress and do a sweeping sort of a motion and bring the tip of the needle outside. So this XNet device also has scleral markers on the other side. You can exactly measure 1.5 mm. So as you can see here, now I'm retracting the trailing aptic and just dock it. Depress the needle slightly at this point, like how a aircraft would land on a runway. So do it once the docking is comfortable. Retract the needle, and you can give a little bit of counter traction over there, and wait for the aptic to be seen. Once you see the blue portion, then gently grasp it and disengage the needle. That's it. So now XNet is all about exteriorization. It simplifies the way you exteriorize aptics. Now I'm introducing quickly SFix, a new product, not yet commercially available. It's so there are 4 steps in XFix. One is docking. Basically, SFix has 3 components: needle, suture, and a polyamide tube. The second step is you push inside, push the dock polyamide completely inside. Then the third step is take a suture bite from the point of sclerotomy and travels around 2 to 3 mm, partial thickness sclera, and then exit. So now you're creating a sleek suture track for the aptic to be fixed. Beginners can always open the conjunctiva at this point of time so that you're comfortable. So once this is done, the fourth step is you pull. So keep pulling gently the nylon suture. You can see the suture is attached to the polyamide tube. This is what we have done in SFix. That's a USP of this device. And as you pull, the aptic will just follow and get fixed into the sleek suture track that you have formed. So as I said, there are 4 steps. Docking is the first step. You can see the aptic is docked inside the polyamide tube. And the second step is push. You push it inside the polyamide tube completely inside. The third step is suture track. The key is you start from the point of sclerotomy. If you want, you can always open the conjunctiva at this point of time. Travels around 2 to 3 mm with partial thickness sclera. Exit. This is the third step, suture bite. And the fourth step is you pull. Keep pulling. The suture track is already formed, and the aptic will just follow that. First the polyamide tube, then this aptic. Further counter traction would place the aptic over there. So as you can see here, we have not done anything inside, and you don't need a flap, peritomy, glue, a flange, nothing. All you need is a fix and a snake to do a comfortable, esophageal surgery by our novice and anti-segment surgeons as well. It's not only for veterinary surgeons anymore. Thank you.
Yeah, thank you, Dr. Prabhu. Very innovative techniques, both of them. We now have Dr. Vaibhav, who's a veterinary consultant in Arunodaya Deseret High Hospital, Gurugram, and he will be talking to us on iris claw IOLs. You'll cover Dr. Yamane also? One at a time, okay. Yeah. Over to you. Yeah.
Is it a magic board? Can you upload the Good morning, everybody, and it's nice to be here early in the morning. And I would like to congratulate the audience also. We were well turned down from the panel. So, iris clip or retrofixated iris lenses is something which is a very good technique, which the anterior segment surgeons as well as the rear surgeons can practice routinely. And if done safely, it's as effective as retrofixated lens. So, I'll just be going through the key steps of the surgery, making it it simpler step by step so that this can be reproducible. And there are some key learning points also which we can keep in mind while doing the procedure. Good. It is fine. It's there on the. Yeah. So we start very important. The most important step in all these secondary IOL surgeries is you have to clear off not just the anterior vitrectomy, but you also have to make sure your own area is clear and you do a very good core vitrectomy. And ideally, you should always do a proper posterior vitrectomy. So in this case, they want to drop IOL. So very, very important to the posterior vitreous attachment as a VR surgeon. And make sure that the IOL is free from the vitreous attachment or reverse. Just some few other additional tips which can always
Thank you, Dr. Weber. We'll keep the discussion towards the end in the interest of time. We now have Dr. Nivian, who's a vitreoretinal consultant at MNI Hospital, Chennai, and he'll be talking to us about his innovative CMT Flex IOL.
Thank you, Shishir. They're uploading it from there. Just a minute, I think just uploading it. Nivian.
just to show up, and how many of you do iris claw IOLs you raise your hand? Iris claw IOLs. How many of you practice? 3 people practice. And self-fixated lens, which type do you recommend? CMT flex lens?
Nobody knows about it yet, so that's why I'm here.
And Yamane technique? Yamane and suture technique? Chariot taper technique?
8 o'clock. It's not uploaded yet. Where was yours? It's not showing here.
Yeah. Open. Not visible here. It's not showing.
If the next speaker is ready, I'll up. Can I just put the pen drive here and present? It's there.
Meanwhile, if you have any questions, you can we can discuss.
The saturation of IL with XNIC techniques will it be possible after you implant
The S-fix you are talking about?
XNIC technique?
Yeah, do. See, basically, XNIT can be combined with any of the fixation. Is a presentation ready? It can be combined. You can combine with glued IOL or Gebauer technique. That's not an issue. You can always adjust the haptics. But what we have introduced is S-fix. S-fix, you can a little bit of haptic will show up after you exit. So that can be pushed. That's not an issue.
Yeah, we have Dr. Ashray. He's currently working as a vitreoretinal consultant in Eye Foundation, Coimbatore, and he'll be talking to us about the glued IOL.
So good morning, one and all. I'll be talking on glued IOL. This is my financial disclosure. I work as a consultant for biotech healthcare. So there are 4 situations where you will need to do any of these techniques. But I strongly feel all the techniques had a partial vitrectomy, and glued IOLs or secondary IOLs are realm of vitreoretinal surgeons. So simply because in the era of refractive surgeries, you need to have a refractive-like outcome at the end of the surgery. And I will just reiterate a few points on how we can achieve it. So when you have a situation where the patient has a subluxed lens or dislocated lens, or when the patient can, this is a IOL which cannot be repositioned, and you can see the tilt also, which is evident on this antersegment OCT, or when everything looks innocuous aphakia, but there is a massive vitreous prolapse in the AC causing decompensation of the cornea. Those are the things which we need to really give attention to and do. IOL is just a part of the surgery. You have to take care of all these things, and which is can be only be effectively managed if you have a good vitrectomy system in your hand. And this is iris clip IOL, where you can see not everyone is as good a surgeon as Vaibhav. So average surgeons like me can struggle with techniques like iris clip IOL. And patient, even though patient can have 6/6, but because of the Stiles-Crawford effect, he might be complaining of visual problems. And of course, on OCT only you will be able to see the vitreous prolapse and all the associated astigmatism problem. And astigmatism is one of the grossly neglected problems in the secondary IOLs. So as we all know, Gaber in 2007 gave this landmark paper, and all the other techniques are basically a rehash of the same principle. The goal of the surgery of any surgery should be restoring the anatomy. We should not distort any of the anatomy, because that is very, very important. So this is where this angle anatomy comes into picture. So this looks so innocuous, but if you see the angle, you will see there are multiple things going on there. There is Schlemm's canal, there is iris root, there is trabecular meshwork, and this is where you are meddling with, and which will cause long-term problems. So basically, Sharra's technique had 2 main things. One is 1.5 to 2 mm from away from the limbus, which actually is the danger area which we should avoid from, and also to achieve an effective lens position and alignment, which will give you very good refractive outcomes. So this is a case where, sorry. So as you all know, this was a subluxed lens, which I tried initially with the cutter, but it is after partial vitrectomy, it is always better to use a phacophragmatome. Even though it, however soft it may appear, it will reduce the operating time drastically. once it's done, there can be an associated breaks which can be lasered and finished off on the table itself rather than doing it post-operatively, which an anterior segment surgeon cannot be done. And marking these with the RK marker at 180 degrees apart is extremely important. And once you mark that, you make a measurement of 2 mm, and with the help of this handshake technique, you can exteriorize. But in this case, as I told, the previous speaker mentioned, the risk of lens drop. If it happens also, it's of no issue. We can always refixate by elevating with an extrusion cannula, and by measuring at 2 mm, you can give almost an effective lens position like alignment, and you don't have to change with the biometry as well. And this is the Chariot's tunnel, which will help you to fixate without needing any additional equipment. And once you exteriorize the haptic and nudge it into the Chariot's tunnel, you can close it with the glue. So this is another case where there was IOL drop where we cut the lens and not able to. So we used a lens cutter to without enlarging the incision, we removed it, and then injected a new IOL, and the same technique can be used. So this is a case of a multifocal IOL where I fixed a multifocal IOL. If you follow the principles, you can achieve alignment where you can achieve centration like a normal lens, and also get rid of any post-operative visual problems. This is the patient who had an outcome of 6.6 and 6. I have done multifocal SFILs also, and this is a very good technique, and we can have refractive like surgery like outcomes. And this is the Chariot's tunnel which I'm showing on OCT, where how the haptic is being tucked into this thing. This is the kind of IOL centration we can achieve. And in these days, medical legal issues are definitely a problem if you have suboptimal outcomes. This is one case where patient had a PCR and a suboptimal outcome. So you should choose the right technique to have a good refractive like surgery like outcomes. And this technique, any of these techniques can be a refractive doppelganger, and definitely glued IOL scores above all these techniques. Thank you.
Thank you, Dr. Ashray. An excellent presentation. We now move on to Dr. Nivian, who will talk about his innovative CMT Flex IOL.
Yeah. So, respected teachers, senior ophthalmologists, my dear friends. So, I'm going to talk about a CMT Flex IOL, a new option for aphakia. Ready? Huh? Yeah. So I do not have any financial interest. So as you all know, all innovations come with a question why. So did mine 6 years back. So these were all the techniques that were there, started from the suture technique 30 years back, and then the modified by the Gabor Chariot. All the previous speakers have already highlighted upon each of the technique, and then externalization of the haptics and tucking it with glue. Amar Agarwal, it's been there for more than a decade. And then the various modifications like the X-Nick technique, and then the Yamane technique of bringing the haptics out and then cauterizing it and making it into a bulb. So all these were modifications of the existing 3-piece IOL. So thought, why not have a design that is there for aphakia management? So this is actually a hydrophilic single-piece IOL with specialized T-shaped haptics on either side. So these T-shaped haptics, when pulled out of the sclerostomy, actually pops and opens up and prevents the lens from falling back. So we'll just go through a couple of surgical scenarios. As you can see, this is a case of aphakia. As again, for any secondary IOL, 0-180 degree is very important for the torsional stability. So we make the 2 by 2.5 partial thickness scleral flaps, and 1.5 millimeters away from the limbus, a 23 gauge sclerostomy is made. So these lenses, because it is a foldable hydrophilic lens, can be done through any of the clear corneal incisions. So as you can see, as you inject the T-shaped haptics coming out first, and grab it with the specialized T forceps head on. So the various parts are there, the head is there, the neck is there, you can also catch the head, but when you hold at the head, when you pull it out, it actually bends forward. So this makes it easier to pull the lens out. At this point, don't pull it out because it's a single piece lens. So inject the remaining of the lens inside, keep the trailing haptic at the tunnel or above the iris, and then gently pull it. You can see the pop there and the T opening up. So just a small animation clip just to show you how the entire procedure is done. Loading is like any IOL cartridge, so you can use any of your IOL cartridges and through a regular 2.8 millimeter clear corneal incision, holding the head of it and then bringing it out. For the other side, it's the same, using the handshake technique. Again, grasping the arm of the IOL there. So we have the specialized Nishi grasping forceps with serrated edges, because these are hydrophilic material, so you can't use any sharp VR forceps because it can bite into the material and that can cause the breakage of the lens. So once the other side is out, there's no more tucking or suturing required because it stays in position there. So that's almost the end of the surgery. You can either glue the flaps or you can use sutures or even cauterize these flaps. Because these are slightly more bulkier things, there won't be any wound leakage. These are the immediate day 1 post-op pictures and 1 month post-op pictures, and some of our studies of UBM and OCT to show the positioning of the lens and how these things react over the sclera over the years. So then you can start doing it for any other case. You can combine it with other cases and more challenging cases like you do for any secondary IOL. So this was a traumatic young patient who was on maximum glaucoma medication plan for a superior trap. So the glaucoma surgeon went ahead and did the trap. So once the trap was done, so these are the 2 forceps I was talking about with this crisscross serrations, that is for the handshake technique. And this is the T-flex forceps with the broad tip on the top so that it gives you a good grip. At the same time, they are not sharp so that it doesn't bite into the material. Here again, inject the lens. Make sure the T comes out first when you hold it. And then the remaining of the lens, you inject the lens. So once that is done, then pull it out. Because sometimes when you don't do that, when you pull it, when you're injecting, is when it can actually detach. So these are all the mistakes that I had in my learning experience. You can see the both sides. In this particular case, I think we had the sommering ring also. So as you all know, like these are sometimes very difficult and calcified when it's not able to come with an irrigation aspiration. So using this lens as a scaffold, so safely just reducing the bottle height and the other parameters. The sommering ring is also emulsified. All the traumatic synache is also released, and this is how the patient looked at the end of the surgery. Post-op 1 week, a good filtering bleb with clear corneal. You can see the scar, the post-traumatic scar, and a well-centered and round pupil, and the patient was doing well. So as this procedure also, because we are a VR surgeon, I prefer the cannula because sometimes you can do the anterior approach. But personally, I feel it is always better to have an infusion and AC trocar maintainer, because as we all know, the biggest challenge for any secondary IOL is hypotony. So I always prefer the AC maintainer, or I'm more comfortable with the 23 gauge trocar, but sometimes you can do the anterior approach and make sure there's a good vitrectomy. As all the previous speakers are highlighted, for any secondary IOL, the key is having a good vitrectomy for better post-operative results and lesser complications later on, long term. So here again, this was a case of an asteroid hallosis, SICS section done. You can see the superior wound. So we did not open up that. So we didn't have to extend the previous one, just injected a new one, and then the second haptic being brought out. Sometimes if you're very forceful, the other side can also come, but then again, there is a small learning curve for every secondary IOL procedure, and that is how I see it. Sometimes if you you can either glue it or even just cauterize it. So complications, yes, you can have breakage of the haptic or slippage when you pull forcefully out, late dislocations, iritis, but these are all common for any secondary IOL procedure, I would say. And there was a long journey from the drawing board for almost 6 years and 2 different models that were developed. But now it is available in the market, and it is done by Masami, and these are some of the people across the country have started using it, and some of the publications that we have in the various journals. And this is our patent office which we got last year. Thanks to COVID, there was a delay. So once again, thank you AIOS, and big thanks to Dr. Shishir for having me here in this session. Thank you.
So, big congratulations to Nivian for doing such an innovation and bringing it to reality.
Thank you.
It's a lot of hard work, I can assure you that.
Long journey.
A long journey.
important thing, Dr. Nivian presented it also in Russia, and he came back also safely. Congratulations.
Yeah, can you just start again? Yeah, so good morning, everybody. I'll be talking about this glueless, sutureless SFIL, which is basically a modification of the chariot technique, but I use a slightly different instruments. So an example of a 70-year-old male presented with surgical aphakia with, cataract surgery done 5 years back. So I start off with doing a toric marking, and then using a crescent knife, I make 2 incisions just parallel to each other at around 3 and 9 o'clock. So I don't cut the conjunctiva here, but if you feel uncomfortable and you cannot manage the bleeding, you can always cut the conjunctiva. Then I use Pricon 1.5 millimeter keratome to make the chariot tunnels. So that's how I do. I don't use a needle, but I use this keratome to make 2 parallel tunnels to each other. And I always do a vitrectomy, a complete vitrectomy. I put all 3 ports, do a proper anterior as well as a core vitrectomy. Yeah. So if you want, you can do a SICS wound, open up the tunnel, or if you want, you can just go in with your 3.2 millimeter keratome, and then through the cornea itself, you can put the 3-piece IOL. So I do a small superior section, do a proper anterior vitrectomy, remove off the remnants of the bag, and then I do a proper core vitrectomy, make sure no vitreous is there. I don't induce PVD, but I just do a proper core vitrectomy. And after the vitrectomy is completed, like Dr. Vaibhav mentioned, always you should check the retinal periphery. So I check the retinal periphery, and I additionally, I do 360 degrees endo laser, because problems with SFIL, one of the main problems which I have experienced during my fellowship is retinal detachments, and it's extremely difficult to manage once you have RDs happening due to secondary IOL. So I always do a 360 laser. And then I create a small aperture 1.5 mm from the limbus with a 24 gauge needle. So I don't do the XNIT, but some situations where the pupil is small, I do the XNIT technique. So once I open the wound, I use a 25 gauge Alcon max grip forceps, hold one end of the IOL, of the haptic of the IOL, and externalize it. And the second haptic, I just put it inside the vitreous cavity. And then using the same max grip forceps, using direct visualization, I just fish it out. Because once you have cleared off the vitreous, you're not having any problem with the vitreous being entangled in the haptic of the lens. So I just fish it out directly, and then I just insert it into both the tunnels which I created with the 1.5 mm keratome. Yeah, so using a McPherson's, you can just insert it into the keratome, and you can see that you can adjust holding the aptics. Just just wash, do a little bit of AC wash, because sometimes the SFILs, you tend to have a little bit pigmentation, and then you can just cauterize and close, and then I remove all the 3 ports. So no sutures, no glue. If you want, you can make an SICS tunnel, or you can just go directly through the cornea itself using a foldable 3-piece lens. Yeah, so this is how a post-op day 1. He doesn't have a superior iris. There was a huge iris defect superiorly. And this is on the AIOC2023. You can see the centered IOL and post-op day 1 fundus. And I always make sure to do a post-op day 1 OCT as well as follow-up OCT to see, because after you have done a co-vitrectomy. Yeah, thank you. So our final speaker, Dr. Weber, he'll be talking to about the Yamane technique, quite difficult technique. So
Thank you. As the theme is secondary IOL, so I got a second chance to present. Other presentation. So as we all are learning secondary IOLs, and we all have our own techniques to do, because the basic take-home message also would be the technique you're comfortable with. That is a technique and which you give good results to, would be something which you can choose in the long term. And I like to present the first Yamane I did some time back, maybe a few years back, so that we can go through the learning curve and see what mistakes were made. So one thing that I noticed that we sometimes have when you're placing a secondary IOL is a slight transient globe collapse when you're placing the opening of the tunnel. So any steps anybody would like to tell us, how do we prevent a slight globe collapse, the transient globe collapse that will happen when you're inserting the lens, or what is the infusion pressure you like to keep?
So, my 2 cents is, I was doing Prabhu Bhaskaran's technique of docking. It is easy. So you have a tunnel and you introduce a 26 gauge needle and dock it. Very nice technique, superb technique. But we did a study of our data around 80 eyes in the last 3-4 years. And what we thought, all the patients had was some astigmatism. So uncorrected vision was always less. So patient will always complain. So then we'll give glasses, then they're fine, 6.6 and 6.9 and all. So then again, I revisited the paper and saw what Gaber has done. So most of the time, then I stopped doing these tunnels. I always try to inject, and this what he showed about pushing that haptic inside, that handshake technique is very difficult. So by having a lower incision size, you can get away with a lot of these problems. This collapse, hypotony, transient, this thing, and you can have very good outcomes. So in the end of the day, what happens is like a patient would have been advised for cataract surgery. There is some complication. Patient would have come to VR surgeon on the same day. We would have to do at least be around that refractive like outcome. So I stopped doing this tunnel thing. So that will solve a lot of problems.
So one more thing is, IOL tilt is an issue as far as SFIL is concerned. That is not there with iris claw because they have the perfect, iris plane. So I've always seen iris claw IOLs. These patients do much better than SFIL. But in the long term, we need to look at probably Nivian.
Yeah, we also had a large case
study,
series published on claw lenses, but they have very good results, as you said. But the only issue again is they have the pseudo-phacodonosis because of the iris this thing, and some people complain of the shaky image. So that is one problem.
How about the incidence of CME overall?
I think it is slightly higher than the other SFIOL techniques, again because it is clipped on the iris, and sometimes you have these pigment dispersions and iritis coming recurrently. But that is one easy method out. Sometimes when you have a high volume cam cases also, I think claw lenses have given very good results as far as secondary IOLs are concerned. So it should also be one of the options. As Vaibhav said, you should know all the techniques and apply what is suitable for that particular patient, at what point of time you are having the complications, and what you are comfortable with. I think these 3 things are the key take home from this session after knowing all the techniques.
Just to add what Dr. Nivian mentioned, if you look at all the big meta-analysis over the different techniques, actually outcome wise there is not much difference. But the problem is those anecdotal cases where you have badly done iris fixated lenses, where there is when you look at the slit lamp, you have a little bit of cringe in your mind.
those are the cases which are never talked about in real life scenarios. So that is where elective iris clear IOLs is something is very questionable, but there are situations where all these techniques need to be used whenever necessary.
Thank you. We can play the video. Thanks. So this was a patient in phakic. I've already done the vitrectomy here. So I use the AuroView foldable lens. I create the incision. So I've already marked but you can see the marks have got smudged. And I'll come to the different problems I faced when I did my first Yamane. So I nicely placed the lens in the anterior chamber. And now see, the actual location of 2.5 millimeter was way ahead. And the mark was made behind. So the marking wasn't correct. Now I'm using a maxillary forceps here from the side port. I'm having a slight difficulty, but I was able to manage it, keeping patience, and I exteriorized it partially in the tunnel. Then I went to the other. You can see the Snell folding. The Snell folding indicates you've got good adequate length. But this is the stage where I had the problem in the first Yamane. So whenever you're placing the trailing haptic, trying to dock it through the 26 gauge needle, that is where you're going to have the maximum trouble. So, your alignment should be correct. And so what happened was the haptic slipped out. So now I kept patience. I brought out the trailing haptic I kept my plan going. I took it out, and the good part was, as the eye was properly vitrectomized, I didn't have any problems in slightly tilting it back into the anterior chamber, because this is a risky maneuver if vitreous is there. That should not be attempted. So I cauterized the the trailing haptic now already, so that area is secure, and I went back and placed the proximal haptic back into the docking area, again making another tunnel, the same area, bringing it out, and then cauterizing it and placing it back into the tunnel area so that it's not exposed in both these areas, and finally forming the AC. So what I learned from this technique was, is there any way to move next? Can I move next here? I have no controls here. No. The presentation, that's a presentation. This is a presentation. After the video, there'll be some slides. Is it there? Okay, fine. So basically what I learned was that you have to keep patience when you're doing these secondary IOL maneuvers. And the first time, the trailing haptic docking is not that easy. So there is also a modification that Dr. Brian has introduced. You can see it on YouTube, in which he brings out the proximal haptic through the 180 degree across main port. So he brings it out to the outside at 6 o'clock, and then he first docks the trailing haptic. And after docking it and securing it, then he docks the proximal haptic. So that is also one thing you can modify depending on how comfortable you are. And what you need to also keep in mind is, once you've docked one, it's always sometimes better you can exteriorize it completely and cauterize it, so that at least that area is secure now. So you have slight flexibility, because otherwise, as you saw, when you're trying to, your focus is on the trailing haptic docking, you put the extra effort and the proximal haptic slips out. So, that is when you panic, you don't know what to do next. So stick to your plan. Doesn't matter even if it comes out, you can very well dock the trailing haptic back and then go back to the proximal haptic. Both are possible. So there is no one right way of doing it, but the most important thing is doing it right. That means the vitreous should not be there, and those maneuvers should only be attempted if you've done a proper vitrectomy, because otherwise scooping it out so the cavity becomes. So that is why such maneuvers, such surgery should only be done when you've done good vitrectomy. Thank you.
Yeah, thank you, Dr. Weber. Excellent video. Just one question to you. Which all cases you will do iris claw, and which all will you use this Yamane technique?
I think wherever I have the availability of a 3-piece lens, and there's iris tissues also not enough, I would recommend doing the Yamane technique or any self-fixated lens. And again, the eyeball length also matters, the white to white. And other than that, if you're comfortable, the iris claw can also be a good option, definitely.
So I just want to add one point. I've seen this, when you want to create a very good flange, you don't touch the tip of the haptic with the cautery. When you stay at a distance, you get a nice bulbar kind of a flange. But when you touch it, the moment you touch it, it gets charred or burnt out. That's when you will have, haptic erosions in the long run. So that's something which...
Yeah, what Dr. Prabhu is mentioning is absolutely correct because the original M&A was described with PVDF material haptics. What we get in India is Prolene haptics. If you apply too much voltage, it will evaporate. So, looking at doing at the distance is the trick.
And the one more point I would like to highlight is all SFLs, whatever be the technique, the key is where you're creating your sclerotomies. Are they 180-degree apart? Are they symmetrical? If you can create a symmetrical sclerotomy, not to be underestimated, that point that goes a long way in creating, placing an IOL without much tilt.
Exactly. And when you're putting the marks, you make sure the conjunctiva is dry. And you should just touch the conjunctiva, because otherwise what happens is the wet conjunctiva, just smudge marks come. So you will be more confused while making the tunnel.
That's why we provided sclerotomy markers in XNet device. We thought of this point, so you don't have to worry about the marking with the glue or not, blue. So you can just it has got the other end of the XNet device as 1.5 mm mark. You mark it and then reverse it and enter. So that's kind of.
So great discussion from the panel, a lot of tips. So I would just like to conclude the session with some few points. So take home message: one, good preoperative workup and anterior segment assessment. Then second is do a proper toric marking, make sure it's parallel to each other, the marking. Then technique, do what you're comfortable with and what is giving you good results. If the iris is good and intact, for anterior segment surgeons, you can do an iris claw. Or if the iris is devitalized, then you can probably go for an SF IOL. And do a proper vitrectomy, anterior vitrectomy, and even a good core vitrectomy. Make sure there is no vitreous tangled in the anterior vitreous face and tangling with the haptics of the lens. And if the retinal surgeon is doing, always better to treat the breaks and keep in the infusion. You always did an infusion to do these techniques so as to maintain the globe. So any points anybody else would like to add?
One point we've not discussed is the ACIOL. I've seen a lot of old surgeons doing beautiful ACIOL surgeries, and we have faced difficulties. But what is anybody would like to tell us any good takeaway points if you want to do a good ACIOL? What parameters or what suggestions would somebody have? Would they still do it in their practice in ACIOL? Anybody?
Not practicing ACIs, but what tips we can use is white to white measurement of the eyes required to select the accurate size, proper size. Because if we select the smaller lens, there are chances that lens will move and damage the endothelium. If we select the larger lens, it will damage the root of the iris. So good white to white measurement, and then there are charts available from Alcon and Boschelbaum to select the appropriate size of the lens.
I don't do ACIOLs, but I have seen quite a few cases of ACIOL is essentially angle supported lens. If you place it well, it doesn't cause any problem. The decompensation, probably I feel it's more of the surgical events that happen along with ACIOL, the need for ACIOL. Those are the issues will ultimately cause decompensation more than the ACIOL per se. That's what I feel.
Thank you all.
We can all have a photograph with the audience. Please come.